The broadcast is now starting. All attendees are in listen-only mode.
All right, welcome to the September 2019 Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and today I'm joined by Dave Page, Dr. Tony Fernandez, and we have a special guest, Ginger Locke from the Medic Mindset podcast. We're also really excited to have one of the authors of the paper we'll be discussing online with us. So please join me in giving an extra warm welcome to Dr. Winslow, Medical Director for the North Carolina Office of EMS. Thank you so much for being here. And today, the article we're reviewing is called Trauma System Resource Preservation. A simple scene triage tool can reduce helicopter EMS overutilization in a state trauma system. And this was published recently in the Journal of Trauma and Acute Care Surgery. All right. So an important thing about this review, go ahead to the next slide, please, Bridget. So this review is paired with an article that's written by columnist Dr. Tony Fernandez in EMS World, which we call Journal Watch. And we encourage listeners to check out this article at EMS World under the category of education and training. Thanks again to everyone for joining us today. Let's begin. You can use your chat feature on your screen to type in questions as we go, and we highly encourage that, and we'll bring in the conversation as we go. So I think before we start off, it makes sense to introduce what we're talking about. So I'll let you chime in as well, Dr. Winslow. But I think the objectives of this study were first to describe the overall changes in helicopter EMS utilization over time in this particular system. And then the authors tried to identify a way of honing in on these low-risk patients using easily accessible clinical information. But before we go into the actual methods and the results, I was curious as to what made you and your team decide to tackle this study topic.
Well, thank you very much for having me. I really appreciate it. I've always been kind of interested or very interested in helicopter EMS as well as EMS. In fact, when I was a medical student back in the mid-90s, I worked a little bit with Robert Rutledge, who helped set up the trauma registry in North Carolina. He originally did this study. And as an emergency physician who's worked in a level 1 trauma center my whole career for about 20 years now, we've noticed an increase in use of helicopters, and we've also noticed that the costs are increasing quite a bit. So I was very curious about or regarding any ways we could possibly predict the mortality of our trauma patients beforehand and try to come up with a triage tool to better or have a better, more judicious use possibly of helicopters, since they're gotten to be, in some cases, very expensive.
Definitely. I think we've all had some of that experience.
So, I was just curious if the trauma registry could be used to kind of make some of these decisions and get a better feel for what the mortality was in the two different groups. And, the CDC trauma triage criteria has been out for a while, and I was curious if we could use that as a basis, as a basic triage tool to get a better handle on that.
Emily, is it okay if I jump in really quick? Ginger Locke here, calling from Austin Community College. Hi, Dr. Winslow. Pleasure to talk to you. Just last week, our students were talking about and working with clinical decision-making related to the CDC's guidelines for field triage of injured patients. And this scenario comes up all the time. A patient fits into the healthy physiologic criteria that you've laid out in your paper. And Remley, can you say what that physiological criteria is? It was like GCS score and heart rates, ages.
Yeah, from the CDC?
No, I was thinking from Dr. Winslow's paper.
Yeah, so.
And these, yeah, sorry, go ahead.
Right, just some of the basic criteria here We're looking at the heart rate, respiratory rate, and blood pressure, as well as the GCS motor score.
And these were healthy physiological patients who've been in some type of blunt trauma. And from your paper, you were putting them on a no-fly list. And what we came up with when we look at the CDC's criteria is unfortunately, they meet this mechanism criteria in the CDC guidelines. How does the medic who is several hours away from a trauma center combine the findings from your study with the CDC recommendations? How do they reconcile those two?
Well, we kind of simplify the CDC criteria a little bit. We said we're only looking at blunt mechanism, by the way, and we're pretty strict on our age criteria, no geriatrics and no peds. And we also, we don't use any of the mechanism stuff other than it has to be blunt. And we also simplified the GCS because we're only using the GCS motor because Dr. Udekwu, he's a trauma surgeon at Wake Med Hospital in Raleigh, and has cited a lot of research and saying that really the motor segment of the GCS is really the most important part. So we were trying to simplify that. So we got almost all the mechanism stuff except having to be blunt. And we just went through with that because we're trying to keep it simple, both for the folks making the decisions in the field and from a study standpoint.
I appreciated that simplicity because I can imagine the medic on the street, there are multiple patients, triaging transport modes, trying to figure out which patients to send by ground, which patients to send by air. What do you recommend they do based on the findings from your study? What do they do now with these patients who are physiologically stable but have some high mechanism that historically, because of the CDC guidelines, have asked that medic to put that patient, they've asked them to send them to a trauma center, which often, if they're hours away from a trauma center, has resulted in aeromedical transport?
Well, I think there's a few things to keep in mind. One, this is obviously it's retrospective. So, I mean, if you look at the low risk ground patients and the low risk helicopter patients, they both had very low mortality rates. Now the high risk helicopter patients had a higher mortality rate, roughly double than the ground, and that could mean lots of things. It could mean perhaps the ground medics are just triaging those patients to a high level of care because they know they're sick from a physiological standpoint, but they also maybe there's other things going on. They're using their inherent knowledge in, and so it's kind of hard to tease that out retrospectively. So we have to keep in mind that this is retrospective, and a lot of times they might be using their own gestalt about who needs to fly and who doesn't. And this paper might show, since both groups are low risk, that medics are really good at deciding who should fly and who shouldn't because the mortality rates are really low in the low risk anyway. So I do think this brings up the fact that if they're low risk, they seem to have very low mortalities, but I think it's also important to maybe go look at this prospectively also. And I wouldn't say, I think this reinforces the CDC criteria, that it's very good criteria, but I'd also hesitate to say that this is the end all be all, saying medics should always be using these criteria. I mean, they should still, obviously work with their local medical direction and still use their brains. And if this patient still really looks bad off, even with normal physiological criteria, that doesn't always mean, they shouldn't use a ground EMS if they think it's necessary. Another thing to keep in mind, and if this is North Carolina, and we're up to about 17 trauma centers now. We have I feel like a pretty well-developed ground EMS system, some of which even carry blood. So this only applies to North Carolina also, if that makes any sense.
Yes, thank you.
Definitely does, and thank you. I think you've hit a couple of important points there, and for those in the audience who maybe haven't read the entire paper, I think we can spend a little bit of time talking about the methods and those two study populations, because this was an interesting way of taking on a retrospective study. So I'll flip it over to Tony. I know he's got a couple of method-specific questions he wanted to ask.
Yeah, so let's go through, and again, thank you, Dr. Winslow, for joining us today. Let's just go over what the study objective was for all those who are listening, and you had a couple a priori hypotheses that I think were very relevant. So your specific study objective was to evaluate the changes in statewide scene helicopter EMS utilization for all ages. And you looked at a couple different outcomes, right? You looked at mortality was your main outcome, and then you looked at some time-sensitive injury outcomes like ED disposition, and then did some assessments of over triage and cost. And it says here that you hypothesized that the contemporary helicopter EMS utilization was associated with substantial over triage, resulting in increased cost and patient risk of financial harm, and that the increased cost and risk could be reduced by application of a simple scene-based rule derived from easily accessible clinical information. And the rule was, let's just go over that because I think that was one of the questions from earlier. The rule that you had here where you looked at patients who they were ages 16 to 69.9 years with a blunt mechanism of injury, normal GCS motor scale, a pulse rate of 60 beats per minute to 100, respiratory rate of 10 to 29. And can you tell us how you came up with these categories?
They're basically copied from the the CDC trauma triage criteria, and we wanted to keep it simple by only doing blunt, and we kept it. We only used GCS motor because some of the more recent research, especially in the trauma community, is starting to show that really the only important part of the GCS is the motor component.
Awesome. And so you used data from the North Carolina State Trauma Registry from 2013 to 2019, and you said that you compared that to a paper that was done earlier, and you had some relationships with the author who did that paper. Can you tell us kind of some of the differences that you found between the 1987 1993 population to your study?
Yeah, there were definitely a lot more patients transported at that point. I think it was a 7.3% from 7.3% to 9.2% as a percentage, going from 1987 time period to the 2013 to 2015 time period. So I think it went from about 193 flights a year to about 1,500 flights per year. And of course, we've also had expansion of the number of helicopters in the state and number of programs in the state since then also. And that was one reason some of the trauma surgeons I work with wanted to look at the same data, is because it seems like more and more patients were being flown, so we wanted to look at that. But we definitely saw a large increase in the number of patients flying. And we also got some pushback from some neighboring counties, from county governments and other folks like that, who were starting to get upset about the bills being charged. And that's also something that I think it's changed since that time period, because before there weren't as many complaints about that. Yeah,
and we have up on the screen, we have table 1, which is the air medical pre-hospital triage score. And this looks, yours is certainly simpler than this one. This one looks quite complex. Can you talk to us a little bit about some of the difficulties you saw in using this score in the field as opposed to the simplified score that you came up with?
Well, there's two reasons we went with the simpler score. One, just from a data standpoint, it was much easier to pull this data out of the trauma registry, and reliable data. I think you can get the table 1 data from the trauma registry, but I don't think quite as reliably. And we felt much more sure of our data using the criteria we used. And then another thing is, unstable chest wall fractures. What does that mean? It seems like over the years, the research and just my own practical experience shows it's very difficult to decide what's an unstable chest wall fracture in the field. Also, for suspected hemothorax or pneumothorax, just looking at the state data in North Carolina over many years, we've seen a lot of needle decompressions done that weren't really pneumothorax or hemothorax. We weren't quite sure about that, if that was a reliable data point. Multi-system trauma can be very difficult to define, especially pre-hospital paralysis. That's a little harder data point also, but it's still, there's some subjectivity there. And we just felt sticking straight to the physiological criteria was a lot cleaner from a data standpoint and a lot easier from a medic decision-making standpoint.
I think this is really important, and it brings a lot of parallels with the debates that are going on with like the large vessel occlusion stroke scales. So many of those scales tend to be complex, and then there's this trade-off between complexity and accuracy versus actually being able to implement and perform it in the pre-hospital settings.
Yeah, I was actually just listening to a CME discussion about that this past weekend on a podcast I listened to, and they made the point that if you use all those tests or all those different scoring mechanisms, and you basically have to take almost every patient to be 100% sensitive to a comprehensive stroke care center, and you'd overwhelm them. And it's kind of the same thing here. If you call a helicopter on every single person, you catch everybody, but I think the system will collapse from a monetary standpoint.
I agree, and I think you all took a really unique, interesting approach that I wanted to highlight. And so in the case of like strokes, we're trying to find the patients that are the most severe and would benefit from the treatment, whereas here it looks like we're trying to take the specific approach and rule out patients that don't need a helicopter transport. So what was your rationale between deciding to look at the less critical population versus determining who most definitely should go by a helicopter?
Well, mortality is a hard endpoint. So it was really easy to look at who died and who did not die. And my feeling was if the patient didn't die, you can much better make an argument that maybe they had a lot more time to make it to the hospital and they didn't need that higher level of care initially. Whereas if they died at some point, you knew they were you knew they were a very sick patient, and you definitely needed a helicopter for them. So I guess maybe we're going at it slightly backwards, but we just wanted to use the hardest endpoint we could, and mortality is pretty much that.
That's fascinating. This is Dave, and thanks again for being on the podcast. It's a fascinating way to look at it, and help me a little bit, just from a street perspective. I've had helicopter crews who basically tell me that patient's too sick, they're going to die anyway. That sort of attitude of, wow, we're not loading a cardiac arrest or near arrest into our helicopter. And some of them kind of do it, subtly. They'll just choose to RSI the patient before they load them, and they know that just lingering a tiny bit will really go, wow, this is a traumatic arrest and we're done. Injuries incompatible to life or perception of how critical the patient is really leave us in this quandary of, gosh, how ethical is it to strap a family, a patient with a $40,000 bill for every time we just suspect, but also what kind of liability and risk do we have deciding, wow, this one really doesn't need it, and then it turns out, gosh, they could have, they should have. It feels a lot like the early days, although this isn't early for helicopter controversy. I think we've had helicopter controversies for as long as 35 years is what I have in the business, and I feel like since day one I grew up in the Maryland helicopter system, so that was shock trauma. Even if you're intoxicated and in a crash, your altered mental status is arguably not. We cannot determine if it's the alcohol in your system or the trauma. So people were flown to the Cowley shock trauma system and obviously got belly taps when they were just simply drunk. So this has been a controversy going on for a long time, and I'm curious about your opinion about that. If they're actually kind of past the point of no return, who's salvageable and who makes that decision?
Yeah, well, I was kind of amazed, to be honest with you, when we looked at our data, how low the mortality was in that low risk group. I mean, I think it was I lost it right in front of me. I think it was like 1 or 2%. I'm looking at the wrong table right now, but it was really low. But then you get in the oh sorry, it was 0.4% for low risk ground and 0.6% in low risk helicopter. And then you get in the high risk for helicopter, it was like 12%, which is really high. And obviously, if they're too sick to fly, you can't fly them. If they're, peri-arrest, you probably shouldn't put them in the helicopter. That being said, I think if, in the way we approach it in North Carolina, if you're using a triage tool that's been validated and that everyone in our state, where our North Carolina College of Emergency Physicians EMS committee agree is a good tool, and you use that tool, and granted, sometimes maybe sometimes you miss some, but if you're using a validated tool from a medical legal standpoint, you should be fine as long as you're using something that's been vetted. But if you've shown that people have a 0.4% mortality in a low risk group for ground, or even 0.6% mortality in low risk helicopter, I mean, granted, if you don't use a helicopter, it might take an extra hour to get there, maybe. Although in our state, you're probably not going to be that much longer for ground. I just think it's a little more difficult to show that you need a helicopter for that. So that's kind of my thinking.
I like it. I like it. And I'm going to be kind of a pain in the butt, but a friendly pain in the butt, and just challenge this kind of mortality concept a bit more, in the sense that, could you make an argument like STEMI that flight actually reduces the size of infarct? So not necessarily to do with mortality, but rather, because you're using it a bit like acuity. Mortality is the sort of, smoking gun of, just like we look for the STEMI and we either get to the cath lab and the artery's blocked or not. Here, we're going to fly them, and if in the study they died, then they needed to be flown. But is there an argument to be made that speed of transport here would save organs or would improve quality of life? And can you think that perhaps the endpoint here in terms of mortality is a bit severe? Maybe there's a reason to fly somebody because it would avoid an amputation.
Yeah, I mean, that's a very good point. We were actually first of all, this study might just show medics are really good at making triage decisions, and they put the correct patients where they're supposed to go. So that's the problem with the retrospective nature of it. We had also hoped, one thing we were initially looking at trying to do was to determine not just mortality, because that's easy to show, obviously it's pretty binary, but did they even need a trauma center? And that's what we kind of hoped to show. I'm looking, it's in the paper somewhere, but basically, did they go, the things we looked at, did they go immediately to an ICU? Did they go immediately to an operating room? Did they go to an L&D? Did they have to go to a burn center or burn unit or something like that? And we were unable, using that initial data, the CDC criteria, to show that they didn't need a trauma center. It's just, you couldn't show that they needed it acutely. So you'd have to pare down a lot more. Now, when you started doing a lot more of the mechanism criteria, you were able to parse out a little bit more whether they needed the trauma center services or not. But it got very difficult to come up with the tool based on the data we had to show they didn't need a trauma center. It's just we couldn't show that they needed it acutely. And the other thing in North Carolina, the flight time versus ground time is oftentimes it's probably not more than 30 minutes difference, if that. In fact, we've had lots of times, I'm sure you've seen this, where the ground unit gets there before the air unit. And in North Carolina, some of the units even carry blood on the ground now. So it gets very difficult to tease that apart, I think.
Yeah, I have to agree. I think it's extremely complex to start to mix together the kinds of interventions, and maybe this is the kind of thing that Tony and Remley can tease out in a large data set, like what we've done with research. Shameless plug for our research workshops with ESO data, where we have some outcome data paired with some scene data about the kinds of interventions that are performed. If you have an EMT basic on a scene who can actually decompress a chest because their medical director said it was okay, and they're working in a state where that's allowed, then suddenly that trauma patient goes from a potentially dead patient to an improved patient. and a whole different dynamic is occurring. And I think the same about community hospitals, where you may have a physician who's or some services who are more or less adept or aggressive about their management of trauma, and some of them choose to intervene, some of them will, wait or fly, and the helicopter crew themselves. We've seen helicopters being used to fly the surgeon to the site in some cases, so that they will perform an amputation or give blood. And then there's the, is that crew configuration or service rendered going to affect the mode of transportation, the actual separate the vehicle, the helicopter or bicycle or ambulance or chase car, with the talent and the ability or permission to perform certain procedures.
Well, I mean, it's funny you should mention that, because we've been working on a pediatric trauma needs assessment for the state, and we've gone back using pre-hospital data, which is, it's basically ESO data at this point, to define what is a sick kid. We basically use vital signs, Glasgow motor scores, and procedures, whether they need an airway, whether a bag valve mask, whether there's a crike done, and we define severity based on vital signs and/or procedures. And what we'd like to do is we'd link those definitions of a severe kid. You could do the same thing with adult to outcome data in the trauma registry. It's just been very difficult to make those linkages. Now we have the ESO Health Data Exchange where I work, and it would be a lot easier on a small scale to do that here. And that would be really cool to do that. Another thing I've just learned recently, looking at some of the data, if you look at the patients that get RSI in the field, some of the systems have been able to follow those patients throughout their whole hospital stay. And they've kind of shared that with me in confidence, so I won't say what those outcomes are, but if you look at the in-hospital mortality of a patient who gets RSI in the field, we already know there's about a 4 to 5% chance they're going to arrest in the field within 10 minutes of that RSI. But the in-hospital mortality is enormous. It's really impressive if you can follow that out, which is something I'd like to do on a bigger level, because I've got 2 or 3 systems who've done that in North Carolina, and it's very surprising how high that mortality is for those patients.
What's your gut feeling, pun intended, about new tools like ultrasound giving us a much more, in terms of things that are time dependent, that have historically been the reason to fly people? Their belly's bleeding, you can't detect it, their vital signs look normal, but in fact they're going to crash later, especially kids. And so you're looking for those tools to say, gosh, noisy environment, very messy scenes, can we really actually determine if somebody's needing an operating room? Do you have some hope there?
Yeah, I actually made a boo-boo once, not too long ago. I had a county who wanted to start doing ultrasound in the field, and I thought it would be fine. Do point-of-care ultrasound, like fast exams. So I said, just doing it, collecting data. We're not making any decisions off that. But they were a county where they basically had to make a decision whether to drive an extra 30 minutes on every patient to go to one of the 2 available trauma centers. And I got pushback from some of those centers, basically saying they thought it was outside scope of practice, and they shouldn't be doing that because it still could, that information could affect their destination. So we've had to pull back on that, and we've had some systems getting pilot data right now so I can take it for the people who help govern our scope of practice in the state. They did it for about 6 months to a year, I think, and they had little issues as far as accuracy and if there were good studies done or not. Over that time period, they might have had an extra 1 or 2 patients that went to a different facility based on that. But just on that very short time period, we didn't have a lot of effect, but that was just one system, and it had just been initiated before we had to kind of pull them back off that. But they were moving forward on that, and it didn't make a huge difference, but I think in the future it could.
Interesting. I think it's important, and that I really love how there is so much possibility for the future to continue this great work, especially with linked records between the pre-hospital and hospital setting and with electronic records, we can get more of the cases available to us to study. But I do want to talk about this important work and highlight how it's going to really serve as a baseline for us as we continue. And one of the things that I see in table 2 is this is really a pulse check on, who are we transporting by ground and who are we transporting by helicopter, and does that seem to make sense? So just a quick look with my naive eyes, I see that, that HEMS patients on average tended to be a little bit younger. They tended to have a higher ISS and some of these other measures. What do you think? Do you think that means that we were doing an okay job at deciding who goes by HEMS, or was there anything surprising in there?
I was just really surprised by the really low mortality in the low risk group, and I was, as I said before, surprised by the 12% mortality is not low mortality. So right. I think we're doing an okay job with what we're doing now, and if anything, maybe the low mortality and low risk group shows we're doing a very good job at triaging already. I do think, given that I've talked to medical directors out west for Western states, and some patients out there, I've been told, I'm not 100% sure about this, but I was like in the 6 figures for what they're being charged, and insurance only pays about, I've heard, around $13,000 for a helicopter flight, and I think we need to do a much better job of how we do it. Not that we're doing bad now, but we need better tools to decide, when these patients should be flown or not. I think we're doing okay, but those are ISS of 14. It's not huge, but it's not minor. It's not minor injury either for the helicopter group.
And so I think my key takeaway from this and what you just said was that we're doing an okay job at picking out the more injured patients or the patients who are more likely to benefit, but we can do better at weeding out some of those who don't need to go by helicopter so they don't incur these excess costs and the excess risk. And so I think tables 3 and 4 did that. And I'll let Tony ask some questions related to the particular methods you used to take a look at these characteristics that might be predictive of low risk patient.
Yeah, so I think this is great. You get to talk about a little stats now. And so you ran some logistic regression models and came up with some odds ratios for mortality. And we can see both of those on here. And let's run through the first one real quick, table 3. So you found that the first independent variable there is helicopter transport, and that odds ratio is below 1. So if they were transported by helicopter, they were significantly less likely to die. They were more likely with every year of age. Blunt trauma was less likely. We have GCS motor score, and this was just for those on the call. These are not continuous variables, right? We treated these as categorical variables based on the categories that you came up with a priori that we talked about earlier. Is that correct, Dr. Winslow?
Yes, although you're the guru on stats, so whatever you say goes.
Well, I appreciate that. But yeah, I want to make sure I'm interpreting your study correctly. So,
that's correct.
Yeah, it looks like the things that you determined a priori were they were certainly relevant when it comes to mortality, and those p-values are really impressive. I think that some of that, and I want to get your take on it, some of the statistical significance that we'll see from these p-values are because you were working with such a large data set, but they are really impressive nonetheless.
Yeah. I still get nervous with really large data sets. Sometimes I think they give, and you can speak to this, sometimes I think they give you artificially low p-values, but that might not be correct. You know more about that than I do.
They certainly can. But I think that's part of the reason why we want to look at these data with a critical eye and make sure that we're fully understanding where the data is. Having an author, having you on to help us interpret these is extremely helpful. So I really do appreciate your time today. So on table 3, what do you think is stood out to you when your statistician presented this to you the most? What would you want our readers to take home from this regression model?
Well, I was just impressed how important GCS motor is. I had never realized until a few years later that GCS motor is such an important component of what's going on. And also, you know, the older you are, I think the more severely you can be injured. And I think that's one thing people tend to forget, which is why we're getting more and more geriatric specific trauma criteria at trauma centers.
Excellent. So, yeah, so now we're talking about table 4. So, and this is where the variables were treated as categorical variables. Excuse me. The first. So I messed this up. I should have read your titles. Table 3 is where they were treated as continuous. So for those on the call, this is age is 25 years, 26 years, 27 years, for every year of age. And the same is true for respiratory rate. They're treated as continuous variables, whereas in the next table, table 4, these are treated as categorical variables, and we can see what the categories are right here. And these stars, they represent what was treated as a referent category. So the referent category, as a reminder, is what we're comparing to. So you see the first predictor, this is transport type, and we've got helicopter EMS compared to ground, and helicopter EMS is the referent, and you can see that odds ratio is less than 1, which jives with what we see above. The age category is interesting because it looks like you did 16 to 69.9, and you combined the age categories of less than 16 and greater than 69 into one group. Can you tell us some of the thought behind that?
Yeah, basically, most of the trauma centers use 16 as their cutoff. Basically, they're saying if you have a driver's license, you're an adult. So that's the kind of the criteria the trauma centers, believe it or not, use about pediatric versus adult. 70, we probably could have gone anywhere with that number. 65 could have been a better number. We chose 70, slightly in a slightly arbitrary fashion, to be honest with you.
And that was a really important variable. I mean, odds ratio of 3.25, that's really impressive, and you can see that was also statistically significant for our readers out there.
I mean, what's amazing with geriatrics, even if just 3 broken ribs, their mortality goes way up just with that alone for geriatric patients.
Wow. Very interesting.
I appreciate you moving it up to 70, though.
Well, yeah, speaking of the 46-year-old, I'm starting to think that way too.
Well, if we're still allowed to nerd out on statistics for a minute, I would like to take a second and really recognize and thank the authors for undertaking this model in 2 different ways. So I think the pure statistician would love table 3 because that uses all of the available data for continuous variables. But the person who wants to interpret and take action based on this study might have an easier time understanding table 4. So when you do what you've done, which is make meaningful clinical categories, it's a lot easier to interpret the results. We say, oh, well, when you're not between 16 and 70, the odds of dying go up a whole lot. Whereas, you know, a 1 unit increase in age is associated with a 1.03 times higher. That's a lot harder to understand to me. So I think this methodology that you all use is just fantastic, and I really like table 4.
Well, thank you.
And then one other thing I want to point out that you highlighted is that GCS motor score. So sometimes it's a little hard for us to interpret small odds ratios, but if we were to reverse the referent category, and I'm going to really go stats nerdy on you, you just put 1 over that odds ratio, that's an odds ratio of like 12.5. So that effect size is absolutely huge. And me, when I'm interpreting these papers, I like to look at the effect size, which is our actual odds ratio, as well as the 95% confidence intervals that you've provided, which show that, you know, the data, there was enough precision here that I'm pretty confident in this analysis. Whereas if you see some really wide 95% confidence interval, we'd have some more questions and probably need a bigger sample size. But in this case, there was plenty of data available, and that variable was surprising to me. I don't know if you felt the same, or based on your research doing the study, that seems to fit.
Yeah, I was pretty surprised that was that impressive on odds ratio for the GCS motor. And the other thing, and speaking as an ER doc who oftentimes can't think that quickly when things are going to heck around me, and I have to use my own card to calculate GCS motor, I think oftentimes some medics will kind of guesstimate the GCS because they're not going to sit here and add up numbers in the back of an ambulance. That's why I just like, are they responding to commands, yes or no? If they're not, they don't have a normal GCS motor. So as a clinician, I like keeping it really simple.
So I love this nerdy kind of, stat stuff, and actually, just to re-explain odds ratios for people who are just like, what is 12 times? An odds ratio of 12 times means there's 12 times the chance that something is correct, and usually like 2 times or 1 point something odds ratio means there's a significant kind of thing. But so help me interpret this from a street perspective. This means that GCS motor alone could give me a sense of fly or no fly.
I mean, I think it could very easily do that. I mean, granted, it's the whole receiver operator curve. Where are you drawing your line? Are you being overly sensitive or not catching enough? But it seems to me if they're not responding to commands, that's enough of a reason right then just to fly.
Okay, well that's very helpful in terms of teasing out of a bunch of different I guess tools. I don't need to calculate anything if you're telling me they don't answer my commands, we're flying.
Yeah, or at least if maybe it's not so much of a fly no fly, but you're going to get that patient to the highest level of care within your system. And if you have to fly to get them there, great. Of course, if the trauma center's across the street or you close proximity by ground, that's good too. But whatever modality gets you to the highest level of care the most quickly with the best care and route, I think is really what I'm thinking, if that makes sense.
Sure. Yeah. No, I agree.
I do agree. Can we go to tables?
I wanted to jump in there for a minute. Hi, this is Bill Toon. So as I love the work that you did, and again, I continue to see some very nice work that comes out of North Carolina as it relates to stuff. So thank you for your continued contribution.
Thank you.
Dave brought this up earlier. This has been, the helicopter issue has been a conundrum for EMS for the 44 years that I've been involved in EMS. And I worked 5 years in a helicopter, and we found that more trauma patients were discharged from the ED than admitted in the system I was working in. And sometimes the trauma surgeons would very clearly say, I'm admitting this person on the hopes that it will help them get a better insurance payment. So your term that you used where we were creating a financial, I forget what exact words, burden or harm, I think is something that really needs to be addressed, because there's clearly distance that is important that needs to be covered with highly trained people. But does it make sense to have 21 helicopters in a metropolitan area? I mean, I'm baffled by the fact that this is just as controversial as RSI is in the out-of-hospital setting, let alone many other things that still come along.
Well, definitely the proliferation of, maybe proliferation is a bad word, but the increasing access to helicopters on a large-scale basis was kind of what prompted this study. And because we really want to get a better handle on, and try to give some better decision tools about when we should use the helicopters or not, because it's, as you say, it's extremely expensive, and I really don't want to bankrupt my patients if I can help it.
Absolutely.
Yes, I don't disagree with you, but I mean, we can go back to the nerdiness because I know we have a lot more nerds on here today than usual. Normally I was only normally able to pick on Tony, but he brought some reinforcements today. So, I mean,
got nerdy muscles here.
That's right. But it is important to read this paper. What I would hope that we'd be able to do it by this point is we need to start being able to link our EPCRs, no matter who the vendor is, along with the hospital records, so we can try to begin to look at this stuff prospectively, because we really do need to find the right tool at the right time for the right patient. And it needs to be, not a financial burden to them when it doesn't make a difference.
Yeah, I think a solid linkage between pre-hospital records and hospital records is a really good solid linkage. That is, it's kind of the holy grail of research and better improving the system. It has always been my take on it.
You know, I think if we're not careful, this is one of those things that has gotten so out of hand that, and there's you know, so much variability and so little certainty on what to do, but definitely harm, financial harm caused to patients who don't need this tool. So you can't say this intervention if you know, we often talk about harm caused by medicine in terms of the physiological outcomes and the quality of life of patients. Bankrupting a family or causing them severe difficulty for them to even have to get a lawyer to get out of having paid the bill is harm. And so the responsibility to make decisions for patients who may or may not be able to, or get their consent to do such a thing when we know at the moment of crisis people will react and say, look, we really need this. Our industry needs to be more responsible about using evidence to make those decisions. And we can't just say, look, just because we think, you know, we have it available or we have a contract, or the helicopter services are really nice people and they give us free continuing education because they want us to make sure to call them. Or we just have an agreement by protocol or because we're part of that same system. We can't, I think, ethically begin to just say, well, you know, if there's any doubt, go. It's like, if there's any doubt, let's immobilize. Well, you know, there it just hurts a little, you get a pressure ulcer, and okay, that's no good. But here, $40,000 later, we definitely have congressional panels. If nobody's been following the news, there's hearings going on, and people are being called to testify to say, how did we have a 300% increase in helicopter medical bills from 2006 to today? And how do we justify the, you know, again, the good of the many versus the good of the few? Can you tell I've been teaching an ethics course the last 2 days? That your Medicare patients who may not pay the full bill, then we're going to just charge the paying customer and those that have insurance a lot more, so that we can forgive bills after a great crisis and threats for the people who just simply really you'll never collect from. So it does feel like a system that is quite messy here, and I think your study is critical to say, okay, look, you know, we have to distill it down to an aviation-like crew resource management checklist that says, is this possible? Is this a good decision? And I think we really need to take those cues from CRM and say, look, are you closer by ground? Is there a different option? You know, is it safe to do so? Where are we landing a helicopter, and what's the weather like? And then eventually we get down to, does the patient obey commands? So that we can have those factors nutshelled into a usable tool on scene.
Yeah. And another thing I think is important, you mentioned on scene, is a lot of these helicopters are auto-launched by the EMD. And I think that's one thing, that's an easy fix. I think really there should be a paramedic there making that decision.
Oh, what a great question. You know, we did a study with the International Association of Dispatchers just regarding this concept of the auto launch, and of course the takeoff and landing of a helicopter, I think, is earmarked at $1,000 just for them to warm it up and lift it off, which I find interesting. They claim, you know, just call us, because if we get up in the air, then, you know, if you are going to use this tool, you don't want to sit around and wait 15 minutes, because by then you've loaded the patient, you're 15 minutes down the road, and then really the time savings becomes nil. So if you're going to use it, you better auto launch it. And now you have agreements with certain air medical providers, or who's the closest, and you do have that sense of, now I have to cancel them, and they're already on the way. So now it's easier for me to just let them go. And it's the catch-22, because you know, frankly, we in Minnesota had been of the mind that we're going to get there and we'll make a decision and then call you. And then, well, 15 minutes later, you're thinking, by then it's only another 15 minutes and I'm to the trauma center, and the cost benefit of this flight becomes irrelevant. I also think we can't forget some of those factors, like a ride in the ambulance is bumpy, and there are some spinal patients who really did benefit from a flight that's nice and smooth, and you know, the location of where you fly, that helicopter returns to, it means monetary income on the part of the hospital. So there's all sorts of sponsorships that make this messy, and it's really complicated.
Yeah, I did. Go ahead. Sorry.
No, I was just gonna. This is Tony. I was just gonna agree with Dave, and I wanted to. One of the things we're running short on time. One of the things we have a lot of budding researchers on the call, and you did some. You had a great conversation or section in your discussion section about the outcomes that you chose that I really wanted to touch on before we wrap today. And the section that I'm talking about was where you said that over a third of the helicopter patients were deemed low risk in the model, but a third of those, 35.9% of the low risk patients had an ED disposition to time sensitive care category, which were invasive procedures or transferred to an IC unit or an operating room. But you found that there was no difference in mortality, even if they had some of these care categories. So I wanted to see if you can talk a little bit about choosing the right outcome for what you're studying.
Yeah. One reason we chose mortality is obviously it was a hard endpoint, but y'all know more about this than I do. But it seems like we're getting away from the kind of the golden hour where there's many time-sensitive illnesses as we thought. In fact, I think we've looked at some of the data in North Carolina. We've had a really hard time showing that increasing the speed which you get to the hospital improves outcomes oftentimes. And I think for this very sickest group, I think that's the case. But originally we had hoped just to try to come up with the criteria to show if they even needed a trauma center or not. So just because they need the trauma center, I don't necessarily indicates they had to get there quickly all the time. Now, a lot of these specialty care things are complex orthopedic procedures, like complex pelvic fractures or acetabular fractures or stuff like that, which oftentimes they can wait, or other things that require a specialist but don't necessarily mean you have to get there quickly, if that makes any sense.
Okay. Well, I love this conversation, and I do think we're running out of time. It is one of those, we used to, this concept of time is really warped. We think, pedal to the metal, let's send all resources, lights, and siren. This is no different in my mind than you call 911 and we send the cavalry. Well, here goes a heavy fire truck, a police car, an ambulance because somebody broke their finger, and we didn't stop to double check. And in fact, we rush back to the hospital only to find out, well, the neurologist isn't there, so suddenly we're going to wait around in the ER. So there's a whole lot of this time-sensitive, well, yeah, but we're going to sit around and wait for the right resource. And in the meantime, it's hurry up, hurry up, hurry up, hurry up. And I don't know that, for example, sepsis, could we give the antibiotic, in the field and avoid this, oh my gosh, we got to rush them to the hospital, and maybe just take the extra 2 minutes without the lights. But I think you're onto something in terms of exactly how much time does this save. And in some cases, our hospitals have helipads that are on the other block, up on the top of the roof of the parking ramp, and you add another 3 to 5 minutes, load, unload, best case scenario, load, unload, get them down to the ER. Whereas some are built for, you land on the roof of the trauma center and the patient's in the operating within 30 seconds. So I think it is how much do we need, how quick is a very good question.
I agree. And speaking of questions, do you think we have a time to take a couple from the audience? I've got a couple of really interesting ones here that I'd
Yeah,
love to.
absolutely. Let's do at least one.
Okay, so one of the ones that I think is really interesting is from Jonathan Epstein, and it's a question about whether it's the mode of transport that matters or where the patient got transported to. So, you know, is air more likely going to a level 1 trauma center, whereas ground might be just going to the nearest hospital? And was that something you were able to take into account for this data set or not?
Well, one reason we use scenes is because all these scenes went to a trauma center. So that made it a little easier. Now, not all the trauma centers they flew to are level 1s. If you go out west, that's going to be a level 2 trauma center. And if you go way to the kind of the southeast part of the state, those are level 2 trauma centers. So they're all level 1s or level 2s. And we did not parse out, you know, if there's a difference in mortality, whether they go to a level 1 or level 2. All that could be very interesting to look at.
Absolutely.
I just want to jump in there. There is literature already out there discussing the differences between level 1 and level 2s and the kind of care that's provided, as well as there is a growing body of literature out there discussing the difference between going to a trauma center versus not a trauma center, with time not being as an issue as once thought. So there's definitely value to the concepts of everything a trauma center brings. The thing that we need to narrow down is how quickly and which ones need to get there very quickly versus those that truly do have time. So
Definitely.
Absolutely. All right, I think we've got time for at least one more question. So this is from Max S, and it says, have you heard of any states or municipalities passing laws to protect patients from overbilling due to unnecessary triage to HEMS?
I have not heard about that, but it gets, when you start getting the state regulation of airlines, because air medevacs, air ambulances are in the eyes of the FAA the same as an airline. So we're not allowed to regulate anything but the medical care that they provide. So I don't know about that, but I think it would be difficult. Y'all might know more about that than I do.
It's out of my depth.
no, you're correct. Your statement is correct. The aviation part of it falls under the FAA. The medical care part of it falls strictly under, you know, who their medical director is. There is a separation there. And just to let you know, we used to carry on the helicopter I work on these little cards that we were supposed to read to the patient regarding exits and what to do in an emergency and everything.
Cool.
I think it's these kinds of studies that are important. So maybe, you know, new EMS researchers don't think, oh, well, a study that I write could impact policy, but certainly putting some data behind this to say that, you know, maybe a third of patients who are transported by helicopter didn't necessarily reap an extra benefit from going by helicopter. So starting to put some hard data into papers like this is extremely important for future policy.
Love it. Well, if anybody is a budding researcher and doesn't yet, know the pathway to do the research, coming to one of our workshops, especially the one at ESO, where Dr. Crow and Dr. Fernandez will be able to help us get that outcome data, is happening September 30th in Austin. It's free of charge, and ESO is hosting it in Austin, Texas. So, I think participating in that helps you really not only just get methodology, but have experts that are on this call tease out and ask the right questions of the data. But we do have to get a little bit sharper and start doing prospective studies. And that research workshop may be a time to plan one of those if you're thinking, gosh, I'm interested in this and we should take a closer look. I'm sure there's much that can be done with what we already have. Well, I think we have to wrap it up. Remley?
All right. I'll go around the room and see if there are any last comments, and I'll wrap us up. So we'll go ahead and start with Bill 2. Any last thoughts?
just thank you for the work that you did, and it needs to be read by every state official as well as many EMS services.
Well, thank you.
Tony.
Yeah, Dr. Winslow, I just want to say thanks for joining us. I think this is great work. I love that you were able to use trauma registry data source for this to publish it, and I think it's really important. I echo what Bill said. I hope everyone can put eyes on your paper, and thanks again for joining us. This is great work.
Thanks so much, Tony.
And Dave?
I just want to say thank you, and I'm going to make sure that GCS motor piece is right in my brain when I say fly or no fly. So thank you for that.
Well, I appreciate y'all pointing that out because I don't think I quite realized how significant that was until I discussed it with y'all.
Awesome.
Absolutely. And I also would like to reiterate everyone's thanks and say thank you for this really important study. I think it is putting patients first and really starts to get us considering the risks and benefits and costs to patients before we do something. So thank you so much for your work.
Well, thank y'all. This has been a great discussion. I really appreciate it.
All right. And for all of you who are online, remember to join us for our Education Research podcast. That's later this month on Friday, September 27th, 10 a.m. Pacific, noon Central. And we'll be back here with the Clinical podcast on the second Monday of next month, which is October 14th. So look forward to seeing you all again. Join us next time.
Thank you.
Thanks.